So I'll introduce the panel. So on the panel today, we have Dr. Muhammad Raza, who is currently working as a consultant in microbiology and virology in the NHS. We also have Dr. Nadia Khan, who is a consultant in palliative medicine at John Taylor Hospice in Birmingham. We have Sherifat Kamal, who currently works as a locum pharmacist across PCN hospital and community pharmacy settings. She actually specialises in HIV and sexual health, and was previously the interim head of prescribing and medicine management for Bromley Healthcare. Dr. Fasih Khan is a specialist registrar in respiratory medicine in Leicester. He's currently undertaking NIHR-funded doctoral research exploring lung fibrosis at the University of Nottingham. He's previously held the position of Chief Registrar hosted by the Royal College of Physicians, and also currently sits on the British Thoracic Society ILD Specialist Advisory Group. He also peer reviews for a number of medical journals and has presented at international conferences. He's also the founder of Empower Youth Academy and is heavily involved with BIMA, being the national director for the BIMA People or HR team. Dr. Wasim Mir is a registrar in anaesthesia in the West Midlands. He covers the intensive care unit and has been doing so during the pandemic. He also works with a Suffolk Institute in Birmingham on community initiatives and has a keen interest in developing understanding amongst the Muslim community on what critical care entails and the Islamic perspective on invasive treatment. Dr. Bushra Choudhry is a GP trainer working in Salford with a special interest in women's health and education. She's an experienced undergraduate tutor for Manchester Medical School and is passionate about tackling inequalities and health and education. She's actually also the chair of Doctors Worldwide and is a trustee for ASDOC, which is a voluntary organisation whose aim is to improve the health of the BME population within the UK. And finally, we have Dr. Hannan, who is a full-time GP in East Manchester. His practice has actually recently been rated, recently rated outstanding by the CQC. And he's also the chair of West Pennine Local Medical Committee and apologies, and chair of the Association of Greater Manchester Local Medical Committees and chair of the World Health Innovation Summit. So thank you to all our panelists for joining us today. So I think we'll begin with a question that we received recently via our survey. And in fact, I'm going to unshare my screen so that you can all see the webcams. So you should be able to see most of the speakers on webcam at the moment. So the first question that we have here is, how can you be aware of asymptomatic carriers, and how long can COVID-19 survive on objects in air, etc.? So firstly, I'd like to ask Dr. Fasih if you can start commenting on that question, please.
Assalamu alaikum wa rahmatullah. Thank you, Jazakallah khair. Thank you to BIMA. Thank you to Marwa for the invite and the opportunity. I hope everyone can hear me clearly. I have had some technical problems, which has involved a move to my parents' house for this webinar, so I hope things are better. So to answer the first question, so how can we be aware of asymptomatic carriers? I think that's probably a bit of a rhetorical question. We can't, and that's the difficulty with COVID-19. What we know is the virus is highly infectious, and people can transmit the virus even before they have a single symptom. And sometimes people can continue spreading the infection and have no symptoms at all, yet get infected and recover and not even know that they had coronavirus. And that's one of the challenges that we face. So I think that first question is a little bit rhetorical. We can't be aware of asymptomatic carriers, which is part of the reason the government's policy and the medical advice is as it is, you know, for social distancing regardless of symptoms, staying at home, and so forth. In terms of the second part of the question, how long can COVID-19 survive on objects? Well, again, I mean, I think as you mentioned in the disclaimer, this is a very rapidly evolving area. It's a new area, and the evidence seems to be changing. I mean, on a weekly basis, what I learned last week is out of date. But essentially, the only paper that has really looked at this is a paper that was published in the New England Journal of Medicine about a month month and a half ago. And what they did is they looked at SARS-CoV-2, so the current coronavirus, and they also looked at SARS-CoV-1, which was the SARS virus from 2003. And what they found is that the virus remained airborne for at least 3 hours and possibly more. And in terms of surfaces, there was variation depending on the type of surface. So on copper, the virus was able to remain viable for at least 4 hours. On cardboard, it was 24 hours. But perhaps most concerningly, on plastic and stainless steel, which is, you know, a lot of door handles and things, the virus was detectable for up to 72 hours. So that means that somebody could have touched that, and then 3 days later, that virus is still viable. Now, it's difficult to know in what quantity that virus is viable. Will it cause infection if somebody then goes and touches that and introduces that into their oral nasal cavity? Or is that just the virus was detectable in terms of RNA? That remains to be seen. But I think, you know, what we do know is that the virus can remain airborne and it can remain on surfaces for longer periods than what we're used to with other viruses.
Excellent. Jazakallah khair for that comprehensive answer, Dr. Fasih. I'd just like to hand over now to Dr. Raza, the microbiologist, just to add a few points to that. Would you like to comment, Dr. Raza? Okay, so I think Dr. Raza is having a bit of difficulty with his audio. So what I'll do is I'll move on to the next question, which is following on from that, should we wear face masks at home, and are homemade masks as effective as surgical masks? So Dr. Fasih, do you think you could answer that?
Yeah, so I think that, again, the first question here, before we ask as to whether we should wear face masks at home, perhaps the broader question is, should we wear face masks at all outside of a healthcare setting? Now, of course, we know that the World Health Organization have said that the evidence for wearing face masks outside of a healthcare setting is very limited, and have therefore recommended that people don't wear face masks. There is evidence that using a mask can limit the spread of infectious droplets from an infected individual to other people. And there have been 2 papers, there's one in JAMA and one in Nature, that have looked at this, and both have demonstrated that if somebody has infection and they wear a face mask, they reduce onward transmission to others. However, in terms of protecting yourself, the evidence is very, very limited. And so that begs the question as to why. And I don't think the answer, again, is clearly known. But one of the theories is about complacency. So what we know is when you are wearing a mask, it leads to a false sense of security. And I notice when I've been in the supermarket and some people are wearing masks, you know, they're touching under the mask, so they're touching their mouth, which defies the purpose. They're touching their eyes. They're not practicing social distancing and hand hygiene as they should. And some people wear the same mask for days. And we know after a few hours, they become ineffective. So should face masks be worn in the community? I think the jury is out. The take-home message is, in my opinion, yes, they should be, but it's really important to do all the other things that we are asking people to do. So, you know, this is what we should be advising our patients. So practice social distancing and all the other things that have been mentioned. So to actually now move on to your question, should we be wearing face masks at home? Well, again, according to World Health Organization, what they have said is that caregivers and family members of affected individuals should wear face masks at home. But I don't think that's based on any evidence, and I'm happy to be corrected. But it seems as though, you know, yes, that's a safer approach, and I think we would advocate that, but I don't think that's based on evidence. That's based on expert opinion. So yes, if you have an infected individual at home, I think people should try and wear face masks. But I think what's more important than that is hand hygiene, social distancing, and not introducing infection by touching your oral, nasal, and your cavities and your eyes.
Excellent. Jazakallah khair for the answer, Dr. Fasih. I'm just going to hand back to Dr. Raza now to see if he's able to to comment on that. So Dr. Raza, can you unmute yourself? So we'll just give him a minute or so. Okay, that's fine. So we'll move on to the next question, which, sorry, Dr. Fasih, is probably also directed at you. So the question is, what is the specificity and sensitivity of current COVID-19 tests? And can we detect past infection?
Sure. So, sorry, just one other thing that I wanted to add to the previous question was about homemade masks. I think I forgot to touch on that. So the Centre for Diseases, CDC, Centre for Disease Control, have recommended cloth coverings. But what's very interesting, in the only study that was published 5 years ago, which was a randomized trial of healthcare workers, of 1,600 healthcare workers, randomized to medical masks, cloth masks, or control group, the rate of infection was actually highest in the cloth mask arm, which is really interesting because actually having no mask at all was actually better than having a cloth mask. And I think it goes back to some of the reasons that I mentioned. So I just wanted to mention that because I think that's important, and I think you asked me that and I forgot to mention it. So moving on to your current question, which was about the sensitivity and the specificity of the current tests. So the current test for COVID is the viral PCR. Now, I don't want to go into too much science, A, because I probably don't understand it myself, and B, it's probably beyond the scope of this webinar. The PCR, we have to remember, detects viral DNA or RNA. And what the PCR technique is, you get a swab which has DNA or RNA, you then amplify that using DNA primers, you multiply it, so you have millions and even billions of copies, and then you match that to the genome or the viral DNA or viral RNA of the virus that you're testing for. Now, with any PCR technique, you need to have a good sample. So the problem is, in COVID patients, there's two problems. One, in terms of testing, one is you may not get an adequate sample. So for example, if you take a swab from the nasal or the oral cavity, you may not get enough cells for you to be able to amplify it. And secondly, the test is positive at different parts of the disease spectrum. So very early on, you may actually have all the symptoms but still test negative. And later, after the first week, the sensitivity of the test also decreases. But what we know is that the sensitivity of the test is about 70%. So about 2/3 of people who have COVID-19 and have the swab will test positive. And so what we do as a result of that, because that's obviously not enough, that's just not good enough as a test, you treat clinically. So if somebody has symptoms of COVID, whether it's fever, cough, or other symptoms, and we'll see more and more, and I think we're going to talk about those later, you assume those patients have coronavirus regardless of the swab result. And putting that together with your blood markers and your chest X-ray findings, that can be very sensitive for, and they are studies showing this, that if you take a patient who has the typical symptoms with the lymphopenia, with chest X-ray findings, that's actually better than doing a swab. Your sensitivity is 90% plus. So to answer the question, the sensitivity is about 2/3, about 70%. It's not a perfect test, and it changes after about a week or so. Can we detect past infection? So with the antigen test, no. Well, the viral test. It's interchangeably called the antigen test, which is actually incorrect. But with the viral test, the viral RNA test, you can't detect past infection because after the first week, 2 weeks, whatever it is, that virus is no longer detectable. So the antibody test, which is the big talk right now, let's talk a little bit. I'll only spend a couple of minutes on this because I know that the answer's gone on a bit. So the antibody test relies on identifying antibodies to SARS-CoV-2. And of course, the antibodies that we look for are IgM and IgG. IgM in the early phase rises, followed by IgG. And that's not just with COVID, that's with any infectious disease. And I'm sure Dr. Raza, if he, once he's back, once his technical issues have been resolved, can answer this in a lot more detail than I can. So what we do here is this is a blood test. So rather than doing a swab, this is a blood test. and you measure the antibodies, IgM and IgG, against SARS-CoV-2. And this will tell you if somebody has had a recent infection or have had a previous infection to SARS-CoV-2. But again, there are many unanswered questions. So the first question is, how long do these antibodies last? So if you have an antibody, if you test me today and I do have an antibody, will I still have that in 2 weeks' time? Will I have that in 3 months' time? If they do last, do they protect against reinfection? We know that there are other pathogens where you develop antibodies, but actually they don't protect you against reinfection. So that question needs to be answered. Is there, and again, this has been demonstrated in studies, is there cross-reactivity with other coronaviruses? So we know the coronavirus is the common cold-causing virus, along with rhinovirus. Coronavirus is actually very common. This is a particular strain that we're seeing, of course. So I know there have been plans to introduce an antibody test, but currently there is insufficient data for just getting a slow network connection message, I apologize. There is currently insufficient data to say that an antibody test should be rolled out across the UK and indeed globally. It is really important that we have adequate data, because a poor test is worse than no test, and we have to remember that. So that's a bit of a, I mean, the government had hoped to have an antibody test ready for the end of this month, early June, and actually put in a number of, has spent millions of pounds putting in an order, from what I understand. But it looks like that order's been cancelled until we have more data.
Excellent. So, Dr. Fasih, you've already answered the question that's also come in about the antibody tests. So thank you for that. I'll just see if I can get Dr. Raza back on the line. Dr. Raza, if you unmute yourself. Just give him a few seconds. Okay, so I think he's still having some technical difficulties, so I'm very sorry about that. So Jazakallah khair for that very detailed answer. Just a quick question that's come through about the immunity of COVID-19. So can you become immune to COVID-19 once you've been infected already, or is there a chance of reinfection? So Dr. Fasih?
So the answer to that is unknown. I mean, you would expect that once you have antibodies, you would have you would be protected against reinfection. But we know that this virus isn't following what we know about science and biology, and we're learning new things every day. And this is the reason this is a global pandemic. So can you become reinfected? Possibly. We would expect not, but until we have data, good quality data, not data from companies or others with an agenda to push out their own test, but independent, well-performed, prospective data, it is impossible to answer that question. But as I said, the expectation would be that you would be protected, but that's just based on what we know from other viruses, and we can't say that with certainty.
So yeah, that's understandable. Does anybody want to add anything to that before we move on to the next question? No? Okay. So we have a question here from Dr. Salwan. So he said that he's a GP who is working abroad at the moment. So he has a few questions actually. So his first question is there strong evidence regarding mutation and multiple strains of SARS COVID-2? And if so, how will that affect vaccine efficacy? So does anybody want to answer that question?
I'm happy to answer that question if.
Jazakallah khair, Dr. Fasih, yeah.
So what we know is that there's one main strain of the virus. Now, if we look at the virus under a microscope, you have a cell wall with these protein spikes. And the protein spikes is what essentially gives it the shape that we see. But also the protein spikes are actually what bind to what we believe ACE2 receptors in different parts of the body. And therefore, that's how the coronavirus infects humans. In terms of the variation in protein spikes, a number of different variations of the SARS-CoV-2 have been identified. But again, it's unclear what that means. Does that mean that, you know, one strain is more virulent and more infectious than the other? Does it mean that one strain is more dangerous in terms of its outcomes? Again, that's not clear. But in terms of the nuclear material, the viral RNA, to my understanding, there's only the single strain that's been identified. It's the viral spikes, the proteins, that vary. But again, sorry, this is a bit of a recurring theme, and I think it will be throughout this webinar, that there is a lot that still needs to be understood. In terms of vaccines, so I don't know. Until we can answer that first question, it's very difficult. So of course, there are a number of clinical trials underway looking at vaccines for SARS-CoV-2. How effective these will be, that's the purpose of the clinical trials, and that's why we need that medium long-term data. But yes, if the virus is what we know from the flu virus, for example, every year the vaccine is modified slightly to take into account the different strains of the virus. Whether that's the case for SARS-CoV-2 is probably going to be the same, but currently, as I said, there's only one main strain of the virus, contrary to what people believe. I think it's just the spikes, and you know, different populations are affected differently, and I know we're going to talk about that later on. So I hope that answers the question.
Excellent, thank you, Dr. Fasih. So we have a question that's come in for the pharmacist, Sherifat. So the question is by Ibrahim Bello, and he's asking, what is your opinion on the acclaimed efficacy of herbal or prophetic medicine on COVID as promoted in some countries? And he's asking that question from Nigeria. Sister Sherifat, would you like to unmute yourself? Yep.
Yeah. Yes. At the moment, there hasn't been any, we all know that there hasn't been any satisfactory evidence that say this is a particular medication that is going to be used for treatment. So herbal treatment, if we don't have any backup trials from any laboratory at the moment, we don't have any here. And I'm not in Nigeria, I'm here, so we wouldn't really, depends on what the kind of pharmaceutical evidence that I have down there. That's to really determine what they want to use. So we can't really say that it's effective or it's not effective until we have an evidence-based clinical trials that's going to tell us exactly what is happening around that area.
Yeah, definitely, and I think we'll probably end up waiting a couple of months for that at least. Anyone else want to comment on that question? Yep, Dr. Hannan.
We've obviously heard from Donald Trump, who announced at the press conference about some of his ideas around UV light and perhaps injecting Dettol and things, which was highly, highly dangerous. And
Dr. Hannan, I'm sorry, can I interrupt you there a second? I don't think your audio is great. Maybe if you move your mic slightly away, maybe that might make things better. Yep, try again.
Is that any better?
Still a bit crackly.
Can you hear
No,
me
still
now?
a bit crackly. No, it was fine
Okay,
earlier,
I'll
so I'm
come
not
off
sure
then.
what happened.
Try again. Is that any better?
No, but I think we can make out what you're saying. So if you want to just carry on, yeah.
It was just saying that Donald Trump announced that perhaps UV light might help, or injecting Dettol and things like that, which is highly dangerous. We've seen examples from other countries as well, where people are talking about herbal remedies and things. We've got to be very careful.
Sorry, Dr. Hannan, I've had to mute you because the audio was quite poor. I'm not sure if maybe you could use a mic on your computer instead of the headset. And just drop me a message when you're done, and inshallah we can reconvene with that question. So we'll move on to the next question now, and I think this is a question for the pharmacist, Sherifat, but anybody can chip in as well. So Likat Natha is asking, my question is, what about the use of hydroxychloroquine, azithromycin, and combination treatments for COVID-19?
At the moment, those are trial drugs at the moment, and they have been found effective in some countries, and they're still using them at the moment. And not until we have a standard medication to use, then we can make them standard. But they are still being used, and they're all trial drugs at the moment.
So if I can just build on that, please. So hydroxychloroquine was actually identified first in a French study of about 21 participants from what I remember. Fairly small study, multiple limitations. But what the authors looked at was viral clearance. So they measured viral, on a swab, the amount of virus after about a week. And they concluded, because in 100% of patients, there was no detectable virus, they concluded that hydroxychloroquine was the reason for that. However, we know that the virus is usually negative after a week anyway. So they didn't actually look at any clinical outcomes like mortality, like ICU admission, like ventilation, things that are actually really important. Secondly, there was no control arm. This was just an observational study. So an incredibly poor study. And I know the president of America endorsed hydroxychloroquine, and which has caused a lot of, it's caused an uproar because it's not based on any scientific data. There are ongoing randomized control trials, as Sherifat has mentioned, which of course will answer this question. But the other agents, I think you mentioned, did you mention antivirals in the question? Sorry, Mara, can you just repeat what was asked?
Yes.
It was antivirals. Yeah. Okay. So again, I mean, lopinavir and ritonavir combination, which is actually a combination which is used in HIV. Now, there have been drug trials. So there was a study published in the New England Journal of Medicine, which actually showed that this combination has no efficacy in COVID-19. There is an argument, was the study underpowered? And therefore, there are still ongoing studies looking at this. But in my opinion, I think we're probably flogging a dead horse. I think the antiviral therapies, lopinavir and ritonavir, certainly probably will be phased out very soon. But there is some controversy around this, but perhaps we can say that for another day. But yeah, just to build on that. So that's basically what's been shown. So New England Journal trial for the antivirals showed no efficacy, and a French trial for hydroxychloroquine, poorly controlled, poorly designed, but multiple other trials. There's other drugs, and perhaps we can talk about those later.
Excellent. Jazakallah khair, Dr. Fasih. Anyone else?
Just add something.
Sure. Sorry, Dr. Nadia.
So I think I've got myself. Can you hear me now?
Yep, carry on.
About the psychological benefit of some of the things that are going around in the communities in terms of self-management, really. So there are, community-based therapies which are being shared on WhatsApp groups. Some things are quite, non-harmful. Others maybe aren't helping the situation, or certainly haven't got evidence. However, I think there's something around people, again, wanting some certainty and the ability to try and do something to protect their health, and we need to take that into account as well. So it's something to bear in mind when counselling people, because often people are coming up to me and saying things like, oh, do you think steam inhalation might help with trying to clear the sinuses? What about vitamin C? All of these sorts of things. So the general take that I'm using is that if I don't think there's going to be harm from it, although I can't say that there's going to be benefit, then actually that self-empowerment might be something that helps people to just cope with the uncertainty of things. Maybe some of the GPs might have a comment on that, whether they've been presented with certain, not old wives remedies, but other things which people feel that make a difference. And actually, do we need to try and help people to cope by doing things which generally improve their health, sense of health and well-being?
Excellent, Jazakallah khair. So we'll move on to the next question. which is slightly related. So what antibiotic would the panelists suggest for treatment in the community for COVID-19 secondary infections?
So, I mean, I can go first, and perhaps the GPs can add or endorse. So, I mean, we know secondary infections, superimposed bacterial infections, are common in post-viral infections. My advice would be to treat as you would normally. So, if you have a patient and you suspect a bacterial infection based on your local formulary, which typically tends to be amoxicillin or doxycycline or clarithromycin, or other drugs, I would treat as you would normally. I would avoid giving antibiotics just in case. So I would take we can talk about the treatment and the management of COVID later. I think that's one of our questions. But certainly, if somebody you think has bacterial infection, and it's going to be very difficult to know this because fever is going to continue, the myalgia and fatigue is going to continue. But perhaps if they start coughing up, phlegm of a particular color, or there's other features to suggest that there may be a superimposed bacterial infection, I would treat with your first line oral agent as you would normally, and it'd be interesting to see what the GPs think.
Assalamu alaikum. Thank you, Fasih. Mirroring what you've just said, we have been in the community advised to use doxycycline first line. But however, if there are interactions or they're not able to have that, then amoxicillin or clarithromycin as we would normally treat a chest infection. But we're going mainly on the sputum production because a cough should be dry usually with COVID-19. So if they're starting to produce sputum and having other symptoms pointing towards a chest infection.
Can you hear me now? Is that any better?
Yep, that's a lot better, Dr. Hannan, yeah?
Brilliant. Okay, so what we've been given is advice within our own CCG to assess the patients to see whether they're otherwise well, whether they've got shortness of breath, whether they've got, if they're having difficulty in speaking, what their pulse rate is, and also what their saturation monitor is. Initially, there was guidance that said you could do this through a video consultation, and I think that was on the term that was a score that Tricia Greenhalgh then put out saying that doesn't work. What we're now doing is asking patients who are getting symptoms and concerned to come down to the surgery to walk a certain distance, 40 steps or so, and then measure the saturation to see if they're becoming hypoxic on exertion. And if they are becoming hypoxic, then to assess them in that regard. Otherwise, it's the same advice as what you've said as well.
Can I just add something from
Yep, Dr. Wasim.
I just wanted to add something from a hospital perspective, echoing something that Fasih's already mentioned, and that's that we should maintain our usual standards of prescribed skills, our clinical acumen, and so on. Just on the point of antibiotics, it's been noted quite often, especially in intensive care units, in sick patients where patients have been on big doses of antibiotics to cover superimposed bacterial infection, understandably from admission, and then as the antibiotics carry on, a lot of people have had candidiasis, fungal infections, renal impairment, and so on and so forth. So we do still see, the usual medical problems that come with overprescribing of antibiotics, and missing common medical issues. And then we'll talk later on about some of the other complications that we've seen. But I thought it was just a good point just to reiterate on the antibiotic point, that we should still, like you've already mentioned, focus on clinical signs and symptoms, patient individualized risk factors, and not just kind of throw caution to the wind without prescribing as well.
Great, Dr. Wasim. So since you're working in hospital, somebody's asked what antibiotics are used in the hospital. So maybe Dr. Wasim and Dr. Fasih, if you can just share your experiences.
Yeah, so I mean, from our obviously this will vary from trust to trust and local microbiology guidelines. We currently use amoxicillin and levofloxacin in our trust. But this, as I said, it's quite a broad spectrum antibiotic that we start on. Often patients who we see in critical care who have ventilator-associated pneumonias end up on tazocin and other stronger agents. But yeah, I mean, I'll let Fasih talk more because he's a medical physician as well as to sort of what happens on the medical wards. But like with any microbiology situation, it's very much guided by your local department and guidelines.
Yeah, so I would kind of echo that. The difficulty that we have, so as hospital physicians, we have all the tools, we've got the chest x-ray and the bloods available within an hour, which of course isn't available in primary care so easily. So we're very used to, patient comes to the door, do a quick clerk, history examination, send off the bloods and obviously check their radiology. And typically if the CRP is up, the white count is up, chest x-ray shows some pneumonia, you start them on some antibiotics depending on whatever is in your formulary. So obviously the curve score, and then you give oral or IV depending on that. The challenge in COVID is the CRP tends to be very high. And the reason for that is there is some evidence that there is, and I'm going to talk about this later, that you have this hyperinflammatory response with the release of interleukin-6. And interleukin-6 is actually a surrogate marker for CRP. So your CRP can be, I've seen ventilated patients with a CRP of 50, and I've seen fairly stable patients, when I say stable, not on ITU, requiring small amounts of oxygen, with CRPs of 300-400. And it's very difficult to know. So, there is no agreement amongst all, medical doctors, respiratory physicians, everyone does things differently. So I know some people put a threshold of 100. The CRP is 100, will start some antibiotics. Others will not give antibiotics. So the chair of the British Thoracic Society, is very well known to me, is very much against antibiotics full stop. You could have a patient with a CRP of 400 and you won't give antibiotics in COVID, of course. There's also a broader issue here about staff, contact with staff. Every drug that you prescribe, whether it's oral or IV, particularly IV, requires contact of the nurse and doctor with that patient. And if the clinical benefit is questionable, which it is, then should we really be exposing staff to going and putting in cannulas, to going and connecting infusion lines, and all the other things, alarms from the machines because the infusion is blocked. There's all sorts of things to think about. So, sorry, it's a bit of a long-winded answer, but the crux of it is that everybody is slightly different. But if there are clear bacterial features, as Bushra mentioned, then yes, antibiotics, oral or IV, depending on severity. But otherwise, we would generally, in hospital, just sit tight, see how things go, and take a supportive management approach.
Excellent. Jazakumullah khair for those answers. We have a question that's come in about symptoms of COVID. So the question is, are there any new COVID-19 symptoms that healthcare professionals should be aware of, for example, rashes? And can you discuss recent concerns about unwell children with COVID-19 and abdominal pain? So maybe I'll start with Dr. Bushra for this one, if that's okay. Or Dr. Hannan. So Dr. Hannan, if you unmute yourself, if you're happy.
Yeah, so when the COVID-19 first presented itself, and even now when you contact 111, the traditional symptoms are a new continuous cough, coughing a lot more than an hour, or 3 or more coughing episodes in the last 24 hours, as well as having a persistent high temperature above 37.8 was the considered symptoms that would lead you to think COVID-19. The more recent data is now suggesting that really only about 15% of patients that have those typical symptoms of fever, cough, and shortness of breath. And there's a whole variety of other symptoms that people are presenting. So you do get a fever, but that's somewhere between 83 to 98% of cases. A cough is 57 to 82%. Shortness of breath is somewhere between 18 to 55%, but that's usually 5 to 8 days after their other symptoms. Tiredness, fatigue, 29 to 69%.
muscle aches and pains, 11 to 14%, poor appetite, 40%, sputum production, 26 to 33% may have sputum, sore throat, 5 to 17%, people having abdominal pain, nausea, vomiting, somewhere between 1 to 11%, and then that's okay. So loss of smell and this distortion of sense of taste. So there's a whole variety of symptoms. That's in the adult population. Amongst children, as we know, very few children have been affected by it, but some could be. And the presentation has ranged from having no symptoms at all right through to severe pneumonia. So it does make it quite challenging to know what the symptoms are that people are presenting with for COVID.
Yeah, that's interesting. Jazakallah khair, Dr. Hannan. So we have a hand raised, and that's Imran Tabassum. So, Brother Imran, I'm just going to unmute you now. So if you unmute yourself, you should be able to ask the question.
Hello, can you hear me?
Yep.
Hi. Yeah. Just a quick question. Really. I mean, I know we talked a lot about about.
Sorry, Imran, can you repeat your question, please? The audio is not great. Saika? Okay, I think I've lost him. Brother Imran, if you can just type your question in the question box. I'm sorry about that. So we've got questions flooding in, mashallah. So I'm just going to pick them depending on the questions that are asked most regularly, just to be fair to everybody. So we have a question here from Dr. Saleh, who's a rehabilitation medicine registrar. And his question is, would we be expecting a rise in critical illness, neuropathy, or myopathy post-COVID, given the high ICU admissions and prolonged stays? So I think this one's for Dr. Wasim.
Hello, yeah, so Jazakallah khair for your question. And the short answer to that is yes. We know that most people who do have a critical illness, whether it's sepsis or being on a ventilator, do develop what's called critical care neuropathy or critical care myopathy. In particular, with COVID-19, patients are usually on a ventilator for at least a week in most cases, sometimes 2 weeks or longer. And then they do also stay on the intensive care unit for much longer as well. There is something quite well known as the post-intensive care syndrome, which in short involves patients patients having long-term sequelae from a critical illness and a stay on intensive care, whether that's a physical thing or a mental, psychological issue. And it does take at least 6 months to a year in some cases for patients to recover their muscle function to pre-morbid states, if at all. So obviously we're still in the early stages of the epidemic when it comes to discharging patients from critical care. But I would personally expect there to be quite a significant increase in patients who are having critical care myopathy. And there will be obviously scope then for rehabilitation and physiotherapy services. There will be a massive backlog of patients who will require follow-up from critical care in terms of the post-intensive care syndrome. So I hope that answers your question, inshallah.
Jazakallah khair, Dr. Wasim, thank you for that. Alhamdulillah, we've managed to get Dr. Raza back on the line. So currently, obviously, we have a few questions forward, but Dr. Raza, is there anything that you want to comment on with regards to the COVID-19 test, the current test, or the future antibody test?
Yeah, I can probably comment on the antibody test for futures. It has a place in epidemiology and status of infection in the community. It has a place in the diagnosis as well. The test for PCR is less than 100% sensitive, and antibody test will complement it. Also, it will detect those people who had seroconverted or who had infection but didn't have symptoms. So it's quite useful test. However, currently the tests available are not, the performance is not good. Some of the tests are as poor as 50%. But currently the PHE and Department of Health are working on a spectrum test which will be rolled out to various labs with better performance, but still it will be in a kind of validation stage. So soon there will be some tests available. A good thing in those tests is that although the sensitivity is less than 100%, something in the range of 70 to 80%, but specificity is quite good, which means if you are detected as positive in the antibody, then it's very likely that you had infection, either symptomatic or asymptomatic. So the specificity is good, although some of those people who had infection may not be detected positive with these tests. So that means the sensitivity is far less. So so watch the space. We will be getting very soon those kits available to test in the lab. So near to start doing it very soon. Thank you.
Thank you for that. Thank you for that, Dr. Raza. That's brilliant. So we have a couple of questions that have come in about the BAME population. So the first question is,
Sorry,
why are BAME... No problem. So, oh, sorry, Dr. Wasim, did you want to say something?
Yeah, sorry, I just wanted to clarify from one of the last questions about the children issue, because it was mentioned about pediatric complications, and I know there's been a lot of worried parents around, some of them probably circulating on social media as well as in primary care and in hospitals. I think if people aren't aware, there was a recent announcement on the news and by the Royal College of Pediatrics and Child Health about a subset of small number of patients presenting with very toxic septic type syndromes, multi-system sort of organ failure, similar to Kawasaki disease and toxic shock. And these kids were very, very unwell, requiring early pediatric intensive care. This also happened in New York as well. What I would say about that is be reassured that it's still very rare, and it's only in its even single figures. I think in London they announced, and the Royal College of Pediatrics has issued a sort of flowchart and guidance. I think it will be shared to you after the webinar, and it's quite a good way of just looking at some of the symptoms and kind of systems that are involved. And obviously, any sick child would be usually referred to a hospital in a pediatric unit. But I just wanted to mention that there is scope for that as coming out from the Royal College of Pediatrics about how to recognise it and refer on if worried about it.
Excellent. Thank you for sharing that, Dr. Wasim. In fact, coming on from that point, we've actually produced a handout for everybody, including the link to the the Royal College of Pediatrics and Child Health website, which has some guidance on this issue. So if you click on handouts, you should be able to see a banner with handouts that's shared, either on the right-hand side of your screen if you're using a laptop, or on the or at the bottom of the phone if you're using your smartphone. And you can just download that straight to your computer or to your phone. So please do have a look at that later on. So going back to the questions that we've received, we've had quite a few questions on the BAME community. So what I'll do is I'll ask them all together because I think there's going to be an overlap of the answers. So the first question is, why are BAME, so Black and ethnic minority individuals, affected more? Is the risk assessment score accurate? And somebody's also asked, there's a lot of talk of vitamin D being a cause for increased incidence and severity of COVID-19 in this community. Do you think this is true? So who would like to answer this? So Dr. Bushra, Dr. Hannan, Dr. Bushra, excellent.
Sure. So if we look at the population of the UK, we know that the BAME population is comprised of 14% of the whole of the UK. However, there is a marked association with the high proportion of the community being affected, 1 in 3 critical cases. And we know from the Office of National Statistics just recently that if you are Black, you are 4 times more likely to die from coronavirus, COVID-19, than Caucasians. And if you are Pakistani or Bangladeshi, this is 3 times more likely, and 2 times more likely if you are from an Indian background. So there is some marked worrying features that is affecting our communities, and we don't quite understand yet why this is. There's been lots of links to socioeconomic deprivation, the workforce that makes up the NHS is approximately 46% from the BAME population. The types of jobs that the BAME population do may make it more difficult for social distancing to have been observed originally, such as we're working in public transport, like the bus drivers in London. Lots of communities live in multi-generational families, so the children who are mildly affected may have infected several generations in the family unknowingly. And I think it's also important to have a look at, you know, a lot of people are saying that it's to do with culture and it's all to do with multi-generational living, and we also need to be careful on how we look at that, because it's almost stating that multicultural living and our culture is a problem and it's causing this, and we need to be mindful that it's not actually a problem, it is something that is associated with it. So we have to be careful about the language that we use when we're talking about the causes that we think that may be associated with the high rates in this population. And also statements that have been put out in the press that the BAME population have not been respecting the lockdown rules has also caused a lot of concern and upset, and I just don't think that there is evidence to say that that is true, and we need to also challenge this. With regards to the vitamin D, there is some debate about this, lots of debate, and as Nadia mentioned earlier, at the moment we know that there is no harm in taking vitamin D if you are well and you don't have any renal problems. I would say that taking a supplement of vitamin D is not going to harm you, and I have advised my friends and family to do that. And but in terms of the hard evidence, we need more research into this to see, is it as simple as a vitamin D deficiency affecting this population? But we just can't say that that's the only reason at the moment.
Yeah, that's very interesting. Jazakallah khair. Does anybody else want to add anything to that? Dr. Hannan?
Yeah, I was going to ask, Fasih, do you want to talk a little bit about the recent landmark paper and the findings?
Yeah, so just building on what's been said already, I mean, I just thought it might be quite useful to talk about a paper that's still it's on a preprint server, so it hasn't been peer reviewed, but a very large undertaking which was uploaded just a couple of days ago. So this was a cohort study, the largest of its type in the world, where 17.5 million patients in England were followed up. So primary care record system 1 was used to identify comorbidities, age, smoking status, ethnicity, and so forth. And these patients were then followed up from the 1st of February until the date of censoring, which was the end of April. And in these 17.5 million patients, nearly 6,000 people died. And what they found is they found a number of things, a number of risk factors that were associated with death in COVID. But what was very interesting was we know that, and the study showed this, being an Asian doubled your risk of dying, and being Black more than doubled your risk of dying. But when they corrected for medical comorbidities, which included diabetes, blood pressure, cardiovascular disease, liver disease, renal disease, and so forth, and when they corrected for the quintiles of deprivation, being Black or Asian in itself was an independent risk factor for mortality. So if you're Asian, you were, from the top of my head, 62% more likely to die. And if you were Black, I think it was 73% more likely to die as a result of COVID. So Now, of course, there are many confounders, and I think this is what Dr. Bushra referred to, that haven't yet, are very difficult to measure. So things like multi-generational households, things like workforce, subconscious, unconscious biases, and overrepresentation in healthcare, genetic factors. There's also an argument about face masks. So we know that the face masks generally are designed for a particular anatomy. Are they unsuitable for healthcare workers from a Black and Asian ethnic minority background? The anatomy tends to be different. We know for BMI, we apply corrections. For a lot of other conditions, we apply corrections. And it may be that the PPE equipment is insufficient. So I think this is a very interesting debate. And I think this is something that, this paper is highly likely that it will influence policy in this country and probably across the globe. It's the largest of its kind, and it was only published. I said it's not been published; it's awaiting peer review, but the findings are out. And so I'll hand back to Dr. Hannan, who I know has some thoughts, and perhaps he can take the discussion forward.
So the question that everybody's asking now is that there appears to be an increased risk for BME. But 46% of the population of the people working the front line in the NHS are BME. We can't all come out of the front line. So what is this risk assessment going to look like? And how are we going to decide who does what? I don't have the answers. I don't think the panel has the answers. But looking around, there does seem to be a few features that various risk assessments that people have published are using. So they're asking things like, for instance, do you have underlying chronic health conditions, in particular high blood pressure, diabetes, angina, if you're overweight with a BMI of over 30, you suffer with asthma or other chronic chest conditions, or perhaps sickle cell trait. Are you immunocompromised or undergoing treatment that may cause you to become immunocompromised? Are you an expectant mother? Staff perhaps who are over 70 years of age, those who are male, obviously those with a BME background, staff who may need to be redeployed during the pandemic, but are already subject to long-term adjusted duties as a result of other healthcare issues. Age is a really interesting one. What's the cutoff point for whether you're considered high risk or medium risk or low risk? Is it 50? Is it 55? Some people are saying 55, some people are saying 60 or 70 even. So there's a variety of different factors. And the other one, of course, is what's your role? Is your role predominantly frontline, seeing patients who have not been assessed, or are you working on an intensive care unit? What kind of PPE have you got for the kind of work that you're doing? There's a whole variety of questions around that. Up till now, I haven't seen any risk assessments looking at the mental health and whether certain people might be at a greater risk of having problems than others. And I know that's going to be a question that me and Nadia are going to talk about later around that. So there's a lot of questions about this. A lot of fear. I'm aware of the fact that a lot of BME colleagues of mine are wanting to know some kind of statement around this. And these are some of the things that we're thinking about.
Can I just add to that? A recent article in the BMJ looked at access to PPE, and there was a marked disparity between the BME population's access to PPE compared to the Caucasians' counterparts. So there's obviously a discrepancy there that we can't ignore. And that was published in the BMJ just recently. So we can't say that there's one thing individually. All these things collectively are going to add up to these scary figures. And we have to bear that in mind. And anecdotally, I have been receiving calls and discussions from doctors working on the front line, talking about their comorbidities and also their fears about having to see patients. In general practice, we are we have drastically changed the way we work, and we are reducing the number of face-to-face. However, there are some things that you just have to see, and that's causing a marked anxiety. So we do need to lobby to get some definitive guidance in order to protect our colleagues and also alleviate some of the fears.
That's a really interesting discussion, and I'm sure many of the audience might have things to add to it as well. What we'll do at this stage, I think, is open the floor to the audience to just, to figure out if anybody else has got any take on this. Any questions or comments from the audience, please feel free to raise your hands or type in the question box. I think Brother Saeed Ahmed had their hand raised. I'm not sure if it was about this or something else, but I will unmute you anyway. So Brother Saeed, you can talk now.
Assalamu alaikum, everyone. Assalamu alaikum to the panelists and to the audience. My name is Saeed Ahmed. I'm a consultant nephrologist, clinical director in my hospital. Just two questions. One to the BME. Our trust, I've obviously highlighted this at a high level, and we've put out some guidance. We touched on the point of mental health, and we're trying to touch on the point of comorbidities. And the confounders are there. So I, at the moment, believe it's going to be all confounders at this moment in time. But it's just the political rhetoric and the emotions are so high in this situation, it's going to drive people to anxiety, and that's where GPs will get involved. So leaving that to one side, thing we are practicing, I want to ask Faish this question, and maybe the intensive care colleague as well. Anticoagulation. So there's not a lot of evidence for this, but people are anticoagulating COVID patients more than you would do for prophylaxis, so going into semi-treatment doses. And I wanted to see if primary care have had any take on this, because as we know, there's no real treatment, but people are looking at evidence. And so we've started some anticoagulation. So maybe you could touch on those 2 points, please. Thank you.
Thank you for your question, Brother Saeed. So who would like to go first?
Yeah, just on the point of, I don't know if Fasih wants to go.
Dr. Wasim?
Yeah, so just briefly on the anticoagulation point, I think later we may discuss about the prothrombotic implications of COVID. Obviously, there's a lot in the pathophysiology about are we treating adequately the prothrombotic complications of COVID, and I think Fasih will talk about pulmonary emboli. But yes, I think we've received guidance from our trust in particular to start a semi-treatment dose of sort of in between the prophylactic and a therapeutic dose of enoxaparin for any patient who is suspected COVID-19. And just anecdotally, I've probably thrombolized 15 patients in the last month for massive Ps, which is a fair number considering I've only done 1 or 2 in my entire career before that. And I think it's probably one of the symptoms of our current situation where we have to be a bit proactive before hard evidence does come out from trials and so on and so forth. If we're seeing patterns emerge on a local basis, trusts are going to have to take some decisions like this. Certainly from our trust, we've just made the decision to start blanket treating people because we've seen massive surges of massive Ps. And I know the intensive care group in London also recommended that on their latest guidance, although much of it was small-scale cohorts of patients and a lot of it anecdotal, and there is some theory behind it in the pathophysiology. I think we will probably see something more concrete come out in the future. I don't know if Fasih will elaborate a bit more on that.
So just only one. So what I wanted to add really is what we do know, and there is a fair amount of good evidence that D-dimers tends to be higher in non-survivors versus survivors. DIC is also more common in non-survivors. And if you look at patients who have ARDS, you can argue that actually, a VTE is a very common complication. You've got an unwell patient, they're in ITU, they've got ARDS, and so forth. But actually, there was a study published recently, it's about 2 or 3 weeks ago, where they found that if you compare patients with ARDS who have COVID versus those patients who have ARDS and don't have COVID, a DVT was nearly 6 times, and a PE nearly 3 times more likely in those patients with COVID. And therefore, a very high index of suspicion is required, and which is why some trusts have asked all patients to have, therapeutic dose or a halfway dose between therapeutic and prophylactic. The BTS, the British Thoracic Society, have actually published some guidance on this just very recently, a few days ago. And what they've suggested is that those patients that are high risk, so for example, they've had a previous VTE, they have cancer, they went to ITU, they significantly have reduced mobility, these patients should be considered for an extended course of thromboprophylaxis. So whilst the patient is recovering from their COVID, they should be having 4 weeks of thromboprophylaxis. And of course, this will affect everybody because the primary care team will, of course, probably have to prescribe or answer questions, when should we stop this and so forth. And we'll probably talk about follow-up later. But we know that VT is a problem in COVID, and that's been shown in numerous studies. And we know that D-dimers and DIC is more common. There's no official guidance, to my knowledge, as to what should happen about thromboprophylaxis currently, but I think that may change in the next couple of weeks. I know there's a lot of work happening behind the scenes.
Excellent. Jazakallah khair for that, Dr. Fasih. Very well answered. So we do have loads of questions coming in, but one important question that I think is related to this one is the complications of COVID. So can you briefly tell us what are the short and long-term complications of COVID? So you've touched on DVTs and PEs already. So maybe Dr. Wasim, you can begin if that's okay.
Yeah, sure. I mean, just as a sort of reflective point for this, as physicians, and there are a lot of physicians on the group and medical practitioners, a lot of people when COVID first came out just had a blanket view that it was like an influenza type syndrome and that it was purely respiratory. But I think as we're seeing more and more, as we learn more and more, we are now developing the sort of knowledge that it can affect different systems. And despite all the death and morbidity from it, it is a challenging time for us as clinicians, and quite an exciting time in terms of learning. So I would encourage everyone to read up as much as possible, obviously from evidence-based sources, and just get to grips, because this condition will be here for the foreseeable future. So I think it's important for us as clinicians to be up to date with our knowledge, as we all are today attending this, but also going back and reading on the pathophysiology behind it. I think we've already touched upon the prothrombotic complications and the hematological side of things. Just a bit about that is that the main theories behind that are that we are causing endothelial dysfunction with SARS-CoV-2. And endothelium obviously is present in multiple organs. It's not just in the vasculature around the lungs. It can be present around the heart, in the kidneys, affects circulation to the brain. So we've seen a lot of patients, for instance, have strokes, especially in hospitals. Some patients, 1 or 2 patients I've seen personally have had encephalitis, COVID encephalitis. There are a few case studies in the literature about this as well. But the prothrombotic implications has probably got something to do with more patients having thrombotic and obstructive strokes. A couple of patients have had seizures, and again, that's been sort of mentioned in the literature. A lot of people are obviously having acute kidney injury. Now the jury's out as to whether that's as part of their illness or whether it's sort of iatrogenic and part of the critical illness that they're having. I know from a intensivist point of view, the initial way we were treating patients in hospital when they were being ventilated was to fluid restrict patients as per traditional ARDS management. Patients were being given frusemide in large doses. They weren't being really rehydrated as you would normally. And very quickly we realized that this was actually causing a lot more acute kidney injuries and renal failure in a certain cohort of patients. So we quickly adapted our treatment for this and switched to treating as you would normally patients who are dehydrated and septic, for instance, and making sure that they at least have a euvolemic fluid balance. But a lot of people have had GI upset. We've seen a lot of patients with ileus, especially in kids. I know there's some literature in the Royal College Pediatrics document, which I mentioned earlier. Patients can have nausea, vomiting, ileitis, and inflammation around the gut. And I think it all comes back to, from what I know about the receptors, the ACE receptors, and where they're present around the body. I don't know if Fasih can elaborate on that. He may have done more reading around that. But yeah, there are multi-system organs affected. The most common, as I mentioned, are renal, and from my experience, thrombotic, so pulmonary emboli.
So the only thing I wanted to add to that was about the complications of fibrosis. So a lot of what we know is from the previous pandemics of SARS and MERS, SARS 2003 and MERS, of course, 2012, 2013. And what we know from fairly poor quality studies is about 20 to 50%, somewhere in between there, of patients, of survivors from those illnesses developed long-term pulmonary fibrosis, as evidenced by CT changes or physiological impairment on gas transfer. And so this is something that's going to affect everybody. So the BTS have issued some guidance earlier this week, which some people may have seen and others may not. So all patients will be stratified into two groups. You'll have patients who were hospitalized and had severe COVID, so ended up on ITU, high, HDU, had high concentrations of oxygen. And then you've got those patients who had so the second group, mild to moderate course, and they were hospitalized but only required small concentrations of oxygen or were treated in the community. And basically, I won't spend too long in the interest of time going through the guidance, but all patients will be offered a follow-up. So the idea is that these follow-ups will take place remotely, so around between 4 to 6 weeks, and this will be a holistic assessment. And it'd be quite interesting to hear some of our panelists' thoughts on this. So not just the assessment of breathlessness, but also the need for rehabilitation, as we've touched upon, ongoing oxygen requirements. Having COVID and surviving COVID is probably going to have a significant emotional and psychological impact. And it'd be really important that that is tackled. So it's exploring any ongoing anxiety, any dysfunctional breathing as a consequence of the infection. And as we touched upon, it'll be really important to look out for a VTE because of the high risk. These patients will then have a subsequent review at 3 months. And at that review, they will all have an assessment of their symptoms. Their symptoms have cleared, great, they're discharged from the system. If they have ongoing symptoms, they will then be worked up with a chest X-ray and subsequent tests, which include pulmonary physiology, walk tests, CT scans, because there's a real risk that many patients will have pulmonary fibrosis. Now, the trajectory of that pulmonary fibrosis remains to be seen, but we know that pulmonary fibrosis, which is my own interest, is a catastrophic condition with a median survival of 3 years, which is worse than many cancers. That's IPF specifically I'm talking about. So the second group of patients, who are the mild group, will be offered a 12-week virtual chest X-ray. And the idea is all of this will be coordinated and conducted by respiratory physicians, so through secondary care, because of course the workload on GPs is going to rise exponentially as well. But of course, we know things don't work that well. And the idea is, so the 12-week X-ray will take place. If it's normal, patients will be discharged. If it's abnormal, then the same pathways that I discussed will be followed through. So that's something for everybody to be aware of. And I'd be really interested to hand over to the panel on 2 points. One, what their thoughts are from a primary care perspective. And secondly, perhaps to our palliative medicine physician about the holistic assessment at 4 to 6 weeks and the anxiety and dysfunctional breathing, and how you feel we can contribute to that as healthcare professionals.
So as a GP, I'm already coming across a number of patients who are feeling anxious. Interestingly, the anxiety isn't as a result of getting COVID-19, but the anxiety is because they've been self-isolating or self-distancing, staying in the house, not being able to meet their family. A number of people have had family who've died and they've not been able to go to the funerals. And Whereas many thought that this will be a few weeks and then the lockdown will shut and everything will go back to normal, the realization that things aren't going to go back to normal is really playing on people's minds. When they then hear about loved ones who've passed away, that has an even greater impact. So in my own, I work in Hyde. We've got a very large Jamia mosque in Hyde, large Bengali population, perhaps about 2,000 people go for Jummah namaz. And this is common knowledge, but the chairman of Hyde Jamia Mosque died of COVID-19. You can imagine the impact that's had on that community. As a result of the fact that the BME are 3 times more likely to die of COVID, we've had our fair share of deaths, particularly in people that you wouldn't expect. So we've had a lot of deaths in nursing homes, which is, I'm not going to say acceptable because it isn't, but somewhat understandable. But there've been younger people that you wouldn't expect who died of COVID-19, and that's really impacted them massively on their mental health. And then there's a second aspect, which is up till now we've been talking about the impact on patients, but what about the staff who've been looking after those patients? And I know Nadia's going to talk later a little bit more about the impact it has on our own mental state dealing with these things. Do you want to add anything, Bushra or Nadia?
I was just going to touch on Dr. Fasih's comment about breathlessness and management of it in the context of COVID. So we're already starting to talk about the syndrome of COVID lung, which may become a term that is more widespread. But essentially, we are anticipating that patients will develop long-term sequelae of fibrosis secondary to COVID, as the respiratory physicians are already identifying. And in palliative care, we do recognise that that need to see these symptoms holistically. So understanding that actually a lot of these symptoms are very interconnected with one another. So particularly breathlessness with the symptom cluster of fatigue and anxiety, actually managing breathlessness, it's not just necessarily the pharmacological, the sort of, very medical aspects that need to be considered, but also the holistic psychological domains, which also contribute to that experience of breathlessness. So it's not just about the physical mechanoreceptors or what's happening within the chest, it's actually about the brain. How are we perceiving that breathlessness experience and what does it mean for us? So yes, we're going to have to think about some of the symptoms a lot more holistically in a broader way than we have done traditionally. But there are pockets of work, particularly in palliative care, where we do already understand symptoms in that way. So that may come to the fore in terms of managing these symptoms adequately and sort of longer term sequelae. Bushra, is there anything you want to add?
I think the mental health of healthcare professionals is very important. Support for colleagues. We're already having some research come out that the risk of suicide is high in the group of healthcare professionals before COVID-19, especially amongst doctors. So this is a worry that it will have a greater impact on the suicide rates. So there are helplines available for healthcare professionals to look at this, and as a GP and an employer of staff, we have to make sure that we are looking after our staff, but also the other colleagues that we're working with. And I just want to touch slightly on annual leave, because we can't go anywhere. We're just stuck in terms of our homes and only going out for one form of exercise a day at the moment. Most of us have cancelled our annual leave. We may have had holidays that we've had to cancel, but it is important. We're only going to be able to save up and carry over a certain number of days, and it sounds great that we'll have an extended holiday at some point, 2021 maybe, but it's important that we do take annual leave to just have a rest. I mean, my screen time, I would say, on my phone has gone up exponentially, like a graph with the cases of COVID, because we're just constantly bombarded with COVID information. We're in several more WhatsApp groups, sharing, research, what to do, cases. So it's really important for our mental health to switch off and just have some COVID-free days, if we can possibly just enjoy the time with the people that we live with.
Absolutely.
Definitely.
And I think
Yeah.
that the psychological fallout for staff is a really important issue that Dr. Amir touched on earlier. I think we'll all have had our experiences where we've been put in essentially some sort of ethical quandary or dilemma as a result of COVID, whether it's a direct issue with COVID infection and the illness, or whether it's the non-direct impact that COVID has had on the wider healthcare system. So one of the topics we were talking and thinking about earlier was actually the idea of moral distress and the impact of that for staff. So after the SARS infections back in 2002, I think it was, Toronto noticed, or the Canadian system noticed, that a lot of physicians actually left the profession. And already we are hearing stories of certain physicians having adverse mental health effects secondary to the corona pandemic, including one suicide that's happened in the US. So we need to be really mindful of this going forward. This is going to be a marathon, not a sprint, and actually taking into account the impact that working in extremely uncertain, stressful conditions for staff, with the level of organisational change that has happened, it's unprecedented. Certainly we haven't experienced it within the Western healthcare system. Things haven't disintegrated, but they look radically different to what they were even 8 to 10 weeks ago. So all of that needs to be taken into account. Not only do we have particular ethical dilemmas that are cropping up where it's not clear what the right thing to do is, but there are also a number of scenarios where actually staff know what the right thing to do is, but they're not able to do it because of the circumstances or the context that they're in. So this causes a tension of its own, that gap between what is right to do and what you can actually do. So a very sort of obvious example for me about this is the moral distress that's been caused for nursing staff when it comes to the visiting restrictions, especially for dying patients, and people essentially being either dying alone or just having healthcare staff there, but actually family members not being able to be there. And that's caused a huge amount of distress. And it's been really important for that to be more widely recognised, so that managers and sort of the people who are developing and running and changing services and systems understand what impact it has for the health care staff on the front line. And part of the way that we've tried to mitigate that as a sort of clinician manager has been to ensure we have as much transparency as possible about decisions that we're making on a systems level, so that frontline staff understand where the limitations are, why the limitations are there, and actually hearing their experience is really, really important, and also taking proactive steps to encourage staff to look after their own mental health, but also communicate and provide one another with support is really, really crucial. So we're going to have to think about this quite carefully and think about how we are going to develop some form of infrastructure which allows those opportunities for care across the system in a way that's never been done before. And this is on top of the issues that we have of a staff healthcare workforce, which is already quite demoralised. The sort of informal routes of support that were there maybe when I was a junior doctor 10 years ago, those things have disappeared. So doctors' messes, the chances to, informally support one another and debrief, coffee breaks, that firm structure, which allowed that mentorship and that peer support, all of that stuff's not there now in a way that it used to be. So how do we support? It's a big challenge, and we're going to have to consider things quite carefully. But I know, Dr. Amir, you've been thinking about that, haven't you, already?
Yes, thanks, Nadia. So I'm a member of the Clinical Leaders Network, and this week the Clinical Leaders Network have put out a document as a discussion document to really raise awareness of this moral distress and this moral injury that you've very well described. Typically, as you said, it's when you as a clinician are put into a position where you are treating a patient and you're having to make choices where normally you wouldn't make that sort of choice. As a clinician, as a GP, normally I'd admit a patient who was really poorly from a nursing home, but because of their comorbidities and frailty, being advised now that actually it's safer for them to stay in the home goes against our own values, our own morals. And the difficulty with that is that you know at the time that you might be making a decision that's the right one, but then it plays on your mind afterwards because you're thinking, what if? Or what happens if, we're getting lists of patients who've died, and you look back and you think, well, I saw that patient a week earlier, maybe if I did something different, there would have been a different outcome. And then it presents itself as feeling very guilty, perhaps not sleeping well, perhaps spontaneously crying, becoming more argumentative, becoming more numb. So these are some of the ways that people are presenting. And I've had patients of mine who've worked in urgent teams, community-based teams, nurses who are working in the hospital, and colleagues, GP colleagues, looking back on decisions that they've made and doing SEAs and thinking, I don't know why I didn't see whatever it was, and start to feel guilty about it. So the Clinical Leaders Network have come up with a matrix that I'm going to try and describe that helps you perhaps to identify whether you might be at risk. So it starts with noticing that you're overworking and pushing beyond what you would normally do. And many of us have noticed that we're doing that because of the COVID pandemic at the moment. The next level is sleep deprivation, where you find that you're not sleeping as well. And so that's the second level. And then the third level is if you've actually been exposed to lots of people dying directly as a result of the work that you've done. And then the fourth is when you start to feel, actually, do you know what? I'm at risk of dying now as a result of the work that I'm doing. And that's why the information that we've received about the fact that we are BME, we're in the front line, we're 3 times more likely to die, you can see why that's starting to play on people's fears. Big difficulty we've got is that both moral distress and moral injury is not a mental illness. And so when we traditionally think of ourselves in terms of, do we fit the criteria for depression or anxiety, because this isn't a mental illness, we won't identify ourselves as such. And we'll just think, oh, just prick yourself. So what is it? What's wrong with you? Your colleagues are also being exposed to the same as what you are. So we don't necessarily come forwards and reach out for help. Then there's another 4 factors that we've also identified, and that is currently we're all feeling well. But then maybe some of us are currently exposed to some other mental illness or some other health problem that might be troubling us. So we've perhaps just been diagnosed with diabetes ourselves, which on its own, it wouldn't have mattered. But given what I've just said at the moment, you can imagine that that's going to add an extra level of stress. And then perhaps in the past or currently, we are suffering with a mental illness. And if we've suffered a mental illness in the past, then again, that's going to play on our minds. And then finally, if we are currently suffering with a mental illness anyway and still trying to work, those are sorts of things start to play on your minds. And if you have all 4 of them, so if you're exposing yourself to risk of dying and you've got a current mental illness at the moment, then maybe, just maybe, you're at a much higher risk. The other factor that makes things more difficult is, of course, we've got the idea of the groups of people that are supposed to be shielding themselves. And they're quite easy, really, but they're also very extreme, because you could be pregnant with a cardiac problem, in which case you should be shielding. And it's simple, because there's there's a checklist, there's a website that you can go to that says you should shield for 12 weeks. But what happens if you're pregnant, Asian, and you suffer with asthma, and perhaps you've had a couple of courses of steroids because you've had recent exacerbations of your asthma? Not enough for shielding in the sense of respiratory and 3 courses of steroids, but you've got a number of factors. And if you're now a trainee, or you're a locum or a salaried doctor, and you're going to your GP partners to say, I don't think I should be seeing patients face to face, how do the partners respond to that? And what should you be doing? Should you be taking yourself away from that? Or should you be asking for more PPE, thinking that's going to protect you? Or actually, is this a sign of the mental illness and you should be approaching occupational health? So that's just a few ideas that I'd love to hear what the panel have to say.
Dr. Hannan, can I just add something here? So we actually have had a few questions coming about shielding. We've had one person in particular who said, I'm worried sick in my workplace as I'm a community pharmacist working in a retail park and have moderate to severe asthma and do have a mask at work and a visor, but I'm hardly ever getting social distancing and often having to remove my mask when speaking to customers as they can't hear me. Plus, the other staff hardly wear PPE from the perspective of being Pakistani. I feel even more vulnerable. I would have liked to shield, but because I'm not on regular steroids, I do not fall into the shielding category according to government guidelines. My GP is thus unable to put me on the shielding. Please can a GP confirm that this is the case? So what would you suggest to people like this who think that they should be in the high risk category?
There are a few options. If a member of the public feels that they are high risk and they haven't received a letter, they can go to the government website and go through a form on there, and then the GP will be notified of the people who have self-identified being high risk. But as GPs, we have quite strict criteria, as Amir just said, about asthma, about certain health conditions. So if you fit nicely in one of those boxes, then we are able to issue you with the shielding letter. And sometimes the shielding letter is not necessarily for the workplace, it's for access to somebody helping with their medication or groceries. So it is important because it has a helping, it helps in that factor. However, for the question, it's very difficult because we have strict criteria. So in terms of, we would be able to say that you are high risk, but in terms of the shielding letter, we're not able to issue the letter. So it's very difficult. And we haven't at the moment, I don't know, I mean, Amir, you can comment on this, being given some good guidance to say if we can use our clinical judgment and then issue a shielding letter. As far as I'm aware, we have to follow the guidelines. And it's very frustrating because all those factors added up, you can see that actually this person is not protected because the staff are not wearing PPE, cannot socially isolate, Pakistani ethnicity, these are all things, and then the asthma as well. So these are all 4 factors. And if a risk assessment was conducted using the BAME risk tools, we would need to know if that would identify her as a high risk in order to be able to qualify for a shielding letter for her employer. But we haven't got that yet, so I'm hoping, and we are lobbying to have more clearer guidance so we can help people in this situation.
Interestingly, I've also had the opposite, where we've had a discussion with a patient to say, should you be shielding and shouldn't you? And then talked about how restrictive shielding becomes for them, and said that, do you really want to be shielded? Because actually by doing that, you are then going to be forced into a situation where you're stuck in the house for 12 weeks. And when it's a bit of a grey area, the patients actually turned around and said, I'd rather not be shielded, but continue to protect myself. But Sherifat, I know you've not spoken very much up till now, and that's a question that's come from a pharmacist. Have you come across that? Have you felt that you're at increased risk yourself? What kind of PPE have you got at the moment, and what advice is your profession giving you? What's your roll college saying to you?
Thank you very much. I mean, it's a bit ambiguous, really, because the way pharmacy is set up, individual, different area, depending on the size and wherever you are working. Because I look around hospital and community pharmacy and GP practice. I mean, it's fine with the GP practice because we're not even seeing patients at the moment. We can just see them, I mean, on the phone. But with community pharmacy, if you are lucky that you're working within a smaller pharmacy, then we say one, two people come in at a time, and we can 2 meter distance outside when they line up. I mean, some community pharmacy, I mean, the non-chain one that are smaller, they showed that you can protect yourself. But we still have some, I would say some staff that is they're not ready to stay by the back of the shield. At the same time, what is provided is just the gloves and the mask itself, if you want to use it. And some pharmacies, sometimes we do have the apron as well. So it just depends on which pharmacy that you find yourself. But if you find yourself in the bigger pharmacy stores that are very, very big, some pharmacy stores, like bigger stores, they converted their photo stores into a bay where people can stay and line up, and one of the staff will come and pick the prescription, take it out, and your pharmacy don't have any contact at all. So some pharmacy, if you're unlucky, I mean, which are not larger stores, they don't have all those things in place. So it just depends on the kind of pharmacy within community pharmacy. And within the hospital, it's quite a bit challenging at the moment, but depending on which ward you are covering. So, I mean, if you are on COVID ward, so you have the full PPE. But if you are within the dispensary, the problem we have, some dispensary are very good. I mean, I was in an hospital a couple of weeks ago. Very good. There's a lot of space, 2 meter space. But another dispensary, this is just too much. So, I mean, it depends on where you find yourself. It's not really an ideal state in some places. And in some places, it's just perfectly well ideal, the space and there's things to work with. But what I would advise, and what I would say that we normally say is people, whatever the condition you find yourself, wear whatever masks and gloves, and the apron is available, I mean, within the dispensary, and that's will do some. But I will just go against the fact that some of the staff are not ready to wear the gloves, not the masks, which is not good at all. So that is the situation at the moment.
You've touched a really important point there, because we've experienced the same thing in nursing homes, where there were some nursing homes, even though they'd been informed about what they should be doing and provided with PPE, the staff didn't feel, or it appeared as though they didn't recognise how important the PPE was. I think things have changed as we've realised, and CCG gone in and sort of really started to become a lot more stricter. And I think as people have realised that, you know, as the numbers of deaths have happened, how important this is. And are you sort of saying that there are still pharmacies out there who aren't necessarily realising how much of a risk there is? Is that the case?
Yeah, I mean, to see some healthcare staff out there that haven't realised how this is. To see some. Because recently, I mean, I still have a talk, one of these cancer assistant, about just staying in behind the shield before speaking to a patient, just to give that distance. Yeah, I mean, we still, I mean, a bit, not too much, but some are perfectly okay, but still some little in there. They're still not well. They're not understanding exactly what is happening, which we need to do. And sometimes even the patient, they're a bit of a challenge sometimes, because everybody wants to come in at the same time. We wanted to give just the medication, but some people want to come in and still go around the grocery as if it's a normal day. They want to go around and do more shopping around. Well, I mean, there are lots of people still waiting to collect their medication, and there's just one responsible pharmacist in there, not two. So, I mean, it's a bit in and out. It's easier with that, with the hospital pharmacy, but within community, with just one pharmacy, a bit very, very challenging. So, which is something, I mean.
And that touches on, and I know we're sort of coming towards the end of the 2 hours, but I wanted to touch a little bit about the myths that exist out there and some of the things that people think. Bushra, you're smiling there. Have you got a few myths? And I know Wasim, I think you had a few myths as well. But yeah, Bushra, do you want to just say something about some of the myths that are out there?
Yeah, I think originally people did not have an idea of how serious it was. It was something that was happening in a different country and it wasn't going to affect us. And very early on, even when the numbers were increasing in London, it seemed like a problem that it was in the south, it was in London, it wasn't going to affect. And sadly now in the northwest, the numbers have overtaken those in London, and Salford, where I work, has the highest number of deaths outside of London now. So, you know, it's changed very dramatically, but people were not perceiving it as a serious threat. And unfortunately, it seems like the media are in a massive rush to tell us when lockdown is going to end, and all speculating about when the end of lockdown. However, you know, there's talk that on Sunday or Monday, Boris Johnson is going to announce an easing of lockdown, and different parts of the United Kingdom have made their own individual decisions, and ours is awaited in England. And that somehow has given people a confidence that, oh, the lockdown might be easing, so things are okay, and people are out and about. Breaking lockdown early, and I've had conversations with people in my family talking about Eid and whether we will be able to congregate on Eid, and I'm saying the same message, that we won't be, we will be living like this for a considerable amount of time. So everyone is looking for the end point, and you know, it's trying to reiterate the message. The end point would be if we have a vaccine that works, or then herd immunity would only be achieved if we have a significant proportion of the population affected, but we don't know the number of the population that has already been infected has immunity, because we haven't tested enough. So we're nowhere near having the correct information for herd immunity or achieving that, I don't think.
I'd just like to touch on another myth which we've had a lot to deal with really in the last few weeks, which is the myth about people going to hospital and being euthanized. You know, people dying, going in really well, and then hours later essentially being killed off by the healthcare staff. That really became a challenge for us in Birmingham around sort of 3-4 weeks ago, when we were sort of in the escalation phase of admissions into hospital. And I think what's become apparent is just the really strange nature of COVID and the way that people deteriorate. So, you know, getting that message out there that actually people can deteriorate over hours just as a result of the illness, and trying to get the public to understand some of the pathophysiology in a really layman way is very, very important. So we're talking about that idea of happy hypoxia, which essentially means that people can be hypoxic, but up and about, laughing, smiling, and then just crashing at home, and a lot of deaths happening in the community that way. So trying to dispel some of the myths around end of life and medications that are being used, and it being a coincidence rather than being causative, is really important. So that's something that we're currently battling.
Jazakallah khair. Thank you, Nadia, for that. MashaAllah, brilliant discussion. I'm aware that we are running out of time. We've had some excellent questions come through, and unfortunately, I don't think we will be able to answer every single one of them. I've just noticed that we've had a few comments regarding the BIMA discussion. So somebody said BIMA increased risk sounds like backdoor eugenics to me, which I'm not sure if somebody can maybe address. And then we had a comment regarding Muslim patients. So Muslim patients are extremely reluctant and refusing to attend hospital even if ill. The main reason is that a family member is not allowed to be with them, and therefore they feel extra vulnerable. Surely the hospitals need to find a way to manage this better and allow a named visitor at all times. So Dr. Fasih and Dr. Wasim, if you can quickly, maybe a quick 10-second, 20-second answer, what do you think should be done with regards to allowing Muslims access to their relatives, and what is being done in your hospitals?
So I think this is a really difficult question. I think this is unprecedented and this is not something we're used to. Our culture is such when somebody's in hospital, a lot of people go and visit. You know, it's a cultural thing more than anything. It's challenging, but I think we have to look at the bigger picture in the sense that if you go and visit a relative and get infected and then, you know, succumb to consequences yourself and other family members, that's going to have an impact. But at the same time, having said all of that, we recognise that this is incredibly difficult for relatives and family members, and there's a lot of discussion about how we can keep them better updated, but unfortunately it is a problem.
Excellent. Dr. Wasim? Dr. Wasim, if you just unmute your mic.
Hello, can you hear me?
Yep.
Yeah, I just want to add on to what Fasih has just said very shortly. It is a difficult area, and I think from what I've seen, I've been on quite in the front line of a lot of young, especially in the Muslim community. I work in Birmingham, and I've seen communication done poorly, and I've seen communication done well. I think what I would say to us as healthcare practitioners is, if you see something you're not comfortable with, definitely raise it and speak to your managerial department or even your body, whoever's in charge. I know in our hospital, initially everyone was very sort of hands-off with relatives coming in, but now more and more we're allowing relatives to come, especially in the end-of-life setting. We've allowed 3 or 4 people to come in. We've explained the risks of transmission of infection, and people are donning in PPE to come and visit their relatives. We've also thought about trying iPads so people can, especially with patients who are extubated, they can just have some visual contact with their family members. And even personally on the phone, when I'm speaking to a relative, I always try and pass a message on to the patient, so that there's a little bit of a sort of contact between family member and patient.
Jazakallah khair. Thank you for that, Brother Wasim. I'm aware it's 4 o'clock, but what we'll do, I think, because we've had quite a lot of interest and many questions that we're yet to answer, I think what we'll do is we'll keep going for another 10 to 15 minutes at the latest. So if the panelists are in agreement with that, is that okay? Excellent. And for the audience, if you do want to leave, that's perfectly fine. There will be a recording available on YouTube. So please follow our BIMA YouTube channel. Inshallah, it will be uploaded in the next 1 to 2 weeks. And please do fill out the feedback form, the link of which is www.bit.ly/COVID feedback. And that's all lowercase in one word. Thank you so much. So just briefly moving on to a question that's actually been asked quite a few times with regards to medication. So there has been a question about ibuprofen. So does taking ibuprofen increase the risk or severity of COVID infections? And then following on from that, we've had questions also about oral steroids. So are they safe to use in somebody with suspected COVID? For example, if they've also got COPD or asthma. And then ACE inhibitors as well. So there was some concern recently about ACE inhibitors and COVID. So can I start with maybe Sister Sherifat, and then if anybody wants to add anything after that, please feel free.
Which one did you start for? The ibuprofen?
Yep.
Yeah, I mean, the Commission for Human Medicine, I mean, IPS NICE guidelines has concluded that there's currently no insufficient evidence to establish a link between the use of ibuprofen or any other non-steroidal anti-inflammatory agent to affect COVID-19 at the moment. So, I mean, that's just that with ibuprofen. I don't know if you have any contrary view about that. So there's no evidence to say there's any effect on COVID-19 at the moment.
Okay, okay. And what about ACE inhibitors?
ACE inhibitors, I mean, because of the way the treatment, the way COVID-19 is being managed, I mean, it's in the individual case basis, people with comorbidity. So at the moment, I don't know if there's any recent evidence. Well, I mean, there's no evidence at the moment I've seen. I don't know if any of the GP has seen anything recent at the moment, but I don't think we have up to, I mean, the last two weeks or so, I've got a case like that. So I don't know if there's anything at the moment.
Just to add, so initially it was believed that ACE inhibitors and angiotensin receptor blockers increase ACE2 expression. That's now been shown to not be correct.
Not so correct.
There's actually some evidence, limited, suggesting that ACE inhibitors are actually beneficial in protecting against adverse effects. So that's the data. So there's no evidence that ACE inhibitors are harmful.
Yeah. Thank you.
And Dr. Fasih, any comments on steroids in particular, particularly with patients with underlying respiratory problems?
Yeah, for sure. So I mean, steroids, of course, are great because they dampen hyperinflammation, but they come with lots of side effects. The crux of it, in a nutshell, is that there's no randomized control trials to guide steroid treatment in COVID-19. The idea actually stems from SARS again and MERS, where steroids were used in those patients, but again, there was nothing really to suggest that it was useful. I think the really important thing to mention here, and we haven't really talked about this, is that in all of this, we mustn't take a blinkered approach, which I think some of us may be guilty of, not on the panel, but as doctors. You know, COVID is, of course, a very real issue, but more people will probably die from non-COVID related illnesses than they will from COVID. And if we look at patients who have asthma and COPD, taking their inhaled steroids and oral corticosteroids when they have an exacerbation is incredibly important, because they are more likely to have an exacerbation and suffer a fatal consequence than anything to suggest that these agents are harmful in COVID. There was actually, so in terms of immunosuppressants, what's really interesting is if you talk to the transplant physicians, what's coming out is that their transplant patients seem to be quite protected from COVID, and they're not seeing the numbers that they expect. And now we don't know if that's because these patients are very sensible, selection bias, and because they're shielding, or if because there was actually an immunomodulatory effect on COVID. And I've just published a systematic review looking at lots of immunomodulatory agents in COVID, and it seems that there is this cytokine storm syndrome where you get the release of pro-inflammatory cytokines like interleukin-1, interleukin-6, and actually taking drugs like tocilizumab and other anti-IL-1 inhibitors like anakinra may have some benefit. But again, there's 39 randomized controlled trials actually in progress. So hopefully we'll have some answers in the next couple of months. But the advice right now is continue your steroids, continue your immunomodulatory agents, continue taking your inhaled corticosteroids.
Thank you, Dr. Fasih. And just following on from that question, there's a question about the home oxygen monitoring scheme that has been rolled out in London. So the asker is wondering, is it worth rolling this out to other parts of the country? And is it an effective clinical monitoring tool? So that's the home oxygen monitoring scheme.
I must confess I don't know a huge amount about this, so I'll pass on that question.
No problem. Does anybody else want to comment?
On what we're doing in primary care. I mean, we know that some practices, such as Amir's practices, are loaning out oxygen saturation probes to patients so they can take their oxygen saturations. And I certainly anecdotally have told friends and family who've been suffering with symptoms to get an oxygen saturation probe if they can. And that's been particularly helpful for those patients who are very fearful of not attending hospital. It gives you a little bit more confidence that they might be doing a bit better. And we know about a condition called silent hypoxia, where the patient may seem like they're not that short of breath when they're resting and isolating. However, they're actually quite hypoxic. So I think the scheme for loaning out the oxygen saturation probes is actually very useful, because the only way that other people would be able to identify if they're poorly enough to go to hospital is when they've already called an ambulance and the paramedics are taking their oxygen saturations, and that's been used by the paramedics to identify whether they take the patient to hospital or not. So I think it would be welcomed, because it's not easy to get the oxygen saturation probes. If you try to buy them online, they're actually very, very expensive or very difficult to get hold of, because so many people are ordering them. So if there was a system where, like Dr. Amir's practice, they are loaning them out, I think that would be very beneficial for the general population.
I wouldn't want everyone to think that we've got lots of oxygen saturation monitors, but what we have done is we've made a little oxygen saturation station in the surgery, and we've made a little short video with my reception staff showing how patients would come to the surgery, go for a little walk around the surgery, and then go across to the oxygen saturation station. There's a perspex glass between us and the patient themselves. The patient puts a glove in, puts a finger into the oxygen saturation monitor, points the finger at the screen, at the perspex screen, so we can actually see if they're desaturating or not. And then what we're doing is, because we know that patients start with symptoms and it might be 7 days down the line when they suddenly drop, we're getting them to come in every day or every other day to get their saturation checked. And that's another way of doing things. And a number of the PCNs have implemented that, so that either individual GP practices do it, or within a neighborhood, patients go to a certain practice to get that checked. I'm aware that people are coming in their cars and checking their saturation, but of course, if you're sat in the car, you haven't done the exercise, so your saturation may be normal at rest. You really need to do it having done some exercise.
That's a great point. Jazakallah khair, all for your input and for your tips. So I think we'll take one last medical question. So hopefully this will be quite quick. I'll pose it first to Dr. Wasim, since you work in ITU. So somebody's asked, to those who are involved in directly using ECMO, or know a colleague who is, please can you describe how invasive it is, and if they know if any patients recovered from its use and quality of life thereafter?
So yeah, I think what the question is referring to is ECMO, so extracorporeal membrane oxygenation. This is, in essence, a last-ditch resort for anyone who has got what we call refractory hypoxia or hypoxemia. So they've pretty much failed all their treatments in COVID. So we're talking about going on a ventilator, then proning on a ventilator, which is lying on your tummy, which takes a lot of staff to do. And that is something which has been shown to improve oxygenation in patients who are on a ventilator or in general with hypoxia. And just as an aside to that, I know you've been talking about managing patients at home through virtual SATS probes and so on. The Intensive Care Society has now actually advocated for patients who aren't on a ventilator to self-prone if it's safe. We know that improves oxygenation and recruitment in the lungs. So patients who are on medical wards, and I think some people have extended this to at home. I know colleagues of mine who have had COVID have just been self-proning and lying down at home to improve their ventilation. So that's just a small aside. But yes, ECMO is essentially cardiac bypass. So there are only a few centres in the UK which do ECMO. For example, Leicester, Glenfield Hospital in Leicester. There are a couple in London and around the northwest. To be referred for ECMO, you have to be in a certain window of your time on a ventilator. So very often it's within the first few days to a week where your intensive care team would have tried proning you and has unfortunately failed with oxygenating you appropriately. You then have to be accepted by an ECMO consultant in their specialist centre, and they do have evidence-based, certain referral criteria. It is highly invasive, like you said, so there'll be a retrieval team usually comes to transfer the patient, and involves quite large vascular catheters going into quite large veins in the neck, which themselves do carry quite big risks to things like blood clots causing bleeding and vascular damage. We did actually have, on a positive note, one survivor who we referred to ECMO, a young person who went for 3 or 4 days, had her ECMO treatment and came back to our hospital, was then extubated and is now on the ward, and inshallah will be going home soon. So it is a treatment that can work, but the mortality on ECMO is close, unfortunately, to 100%. It's around 90 to 100%, mainly because people are so sick by the time they're on ECMO that their body is just sort of given up. So it is a last resort. I don't know if Fasih wants to add anything to that.
No, I've got nothing to add. I think you've covered everything.
Thank you so much for that, Dr. Wasim. So lastly, we have a question on domestic violence. I know we are running out of time, but this is a very important issue. So domestic violence is on the increase as we're on lockdown. What advice can you give to victims? I think I'll ask Dr. Bushra to address this, please.
Sure, it's shocking to see the number of domestic violence calls that have got the figures, they have shot up. And also it's scary because that's only the ones that are being reported, and we know that in, especially particularly in certain communities, the taboo around reporting domestic violence is apparent. So we've probably only seen the tip of the iceberg in terms of the numbers. So it's important to see what resources that we have, and also to make sure that we are putting out the information for people to access help. If somebody is very concerned for their life and they want to call 999, but they are unable to speak because they are in a presence of the person who is abusing them, they can ring 999 and then have the option to dial 55. And that will alert the caller that they are in danger and unable to speak. And that's important, and that's a tool that we can have posters displayed in prominent areas. I mean, the GP surgeries, there's not many people coming in there, so it would need to be out in the community for people to know about it. And also there are lots of domestic violence help groups, support groups, such as the Saheli Centre, which is that they have a centre refuge in Manchester, particularly helping women from the South Asian community and the BAME community, and their website has resources in several languages, so that's a good resource that we can use for our patients and also members of the community. And there is also a group called Northwest Diversity Matters Northwest, which also has similar resources on their website. So I'd advise you to Google them and have a look at the resources available.
Thank you so much for that, Dr. Bushra. So just on the topic of domestic violence, the webinar team are actually arranging a webinar for to talk about this. So we'll have specialists from Muslim Women's Network and counsellors and people who work with domestic violence patients. So if you're interested, please keep your eyes peeled. There will be a date coming up in the next couple of weeks. Most likely it will be either the 30th or the 31st of May. So I am aware that unfortunately we are running out of time. It's been a really interesting discussion and lots of excellent questions from both the audience and from others. Yeah.
Marwa, can I start very quickly, just a couple of minutes maybe, just on how we see the new post-COVID world, because I think we should finish.
So I was going to ask you about that. I was going to say, can you finish on a positive note? So if you're going to call it post-COVID world, if everybody can maybe answer that in about 30 seconds to a minute. How do you see the new post-COVID world, and try and be positive if you can?
Okay, well, I'll kick off then. So I'd really like to think that there's been a much greater understanding for the public as well as ourselves that the safest place is always going to be in your own home with your family supporting you, rather than a GP surgery, community service, or in a hospital. And so being able to self-care, having a better understanding of your health, improving your health literacy, using a lot of the technology like we've done today, so you don't have to meet up face to face, and thinking about how you can help yourself and help others. It's been a great opportunity for us. It's connected ourselves with our neighbours, looking after ourselves and people at shielding and so on. So I think there's going to be a lot more of that.
Excellent, thank you. Dr. Bushra?
To add to that, I think it's a great honour and a privilege that we are able to help people in our jobs as doctors, and particularly in Ramadan, we have an opportunity to make a difference to many people's lives. And I think coming through this, we'll be able to see the positives of how we all pull together, how as a community we helped each other, and we really try to champion the issues that were affecting our community. And I'm so honoured to be on such an esteemed panel with. I've learned so much from just being in part of this webinar with my colleagues here. So it's just so many positives, and one can look back and see what did we do, how did we help, and did we do everything that we possibly could to make our world better.
Thank you, and I've certainly learned a lot myself. Thank you for that. Dr. Wasim?
Yeah, so I'd just like to say a special shout out to the healthcare professionals who often are overlooked, such as the porters and cleaners, especially in my hospital. I think in the last 6 weeks, I've valued them more than I have ever, and my respect for them has gone up. as I'm sure the rest of the medical community and the public in general. So I hope from going forward from this, we value each other a lot more, and I'm sure we will. And also a shout out to the people in the charitable sector who have stepped up on a voluntary basis to help those in need, whether it's the elderly or the vulnerable in our community. And inshallah, we can keep this going, like Amir said as well.
Thank you. Dr. Nadia?
It feels like the world's been put on a bit of a reset. Allah Ta'ala has hit a reset button for us, and there are lots of challenges, but there are also lots and lots of blessings and opportunities which may not initially be apparent to us straight away, but we have to keep the faith, and inshallah we need to be able to, it's about how we respond, not the question of why it's happening. And I would just say that if there is anyone out there who's struggling with the moral distress element of things and the situations that they're in, you know, please do seek help, but also know that there's a lot of purpose in what we're doing as well. So inshallah, yeah, keep safe and keep strong.
Thank you. Dr. Fasih?
It's harder with each person. So many of the things that I wanted to say have been mentioned, but I think for me, a really important one that this has taught is a lesson in humility. And I think, you know, we've made so much progress economically, scientifically, medically, and in every other way. But something so small, something essentially invisible, microscopic, has put the whole world on hold. And hopefully we've realized the limits of our power. So I think it really has taught us humility, and hopefully we'll appreciate each other more as well, and realize that, you know, collectively we can do a lot, but ultimately we're not in control. And as I say, no man is an island. So hopefully that will be some positive to take away from this.
Definitely, thank you. And finally, Sister Sherifat? Sister Sherifat, I don't think we can hear you. So try again. Right, I don't think we can hear Sister Sherifat, so she looks happy anyway, so I'm hoping whatever she's going to say is something that would have brightened our moods. Okay, excellent, that's fine. So thank you all, and Jazakumullah khair for your input. Unfortunately, that's all we have time for today, and I've certainly learned a lot. I hope our audience has too. I'd like to thank each and every one of the speakers. MashaAllah, you've all been brilliant today. May Allah subhanahu wa ta'ala magnify your rewards in this blessed month, inshallah. I'd also like to thank the BIMA's professional development team who've worked tirelessly over a very short space of time to bring this webinar to you, and to the communications team of BIMA who've helped with publicity and advertising. And of course, thanks to everybody in the audience for your contributions. And please accept our apologies for not being able to address every single question and comment. Talking about comments, there has been one important one that I think I'll read out for our listeners. Somebody said that that booths are offering their consultation rooms for patients that are affected by domestic violence. So that's just an important fact to know if it's correct. So thank you to Boots for that. And inshallah, we'll share some more domestic violence resources in our next webinar after Ramadan, inshallah. Again, just to point out to you, you've got your handout section on the dashboard. So if you click on that, you can download the resources that the speakers have been referring to throughout the webinar. And I'd like to apologise also for the technical difficulties we had at the beginning, particularly with Dr. Raza and the screen sharing, so apologies for that.